Okay, welcome to the first of our Shy Network events. So my name is Cupit and I'm a researcher at the University of Leicester in the UK. And I'm joined by some colleagues from around the world who will introduce themselves to you shortly. We've got Grainne and Kirsten and Darren. And we're just looking forward to having a short discussion about how we've used institutional ethnography in our own work, which I hope will be helpful to those of you that are watching this, and I hope can prompt a little bit of discussion. We've got an event booked at the end of August to discuss some of the issues that come out of this and some other institutional ethnography presentations. So let's start by I should say actually that the Shy Network, for those of you that don't know anything about it, we have got some information on a separate little video about that, but it's studying healthcare using institutional ethnography. So this network is specifically for people using institutional ethnography, the brand that's developed by Dorothy Smith, and using that within a healthcare context. So this will be a little bit more applied than some of the discussions that we have in institutional ethnography community, often at things like the ISA and SSSP, and we're hoping that it will be useful to people from outside the IE community that want to know a little bit more about it. So without any further ado, let's introduce ourselves. Kirsten, would you like to start us off and tell us a little bit about you?
Thanks, Caroline. I'm a specialist obstetrician and gynaecologist, so I'm medically qualified. Currently working as the Director of Obstetrics and Gynaecology in Northern New South Wales in Australia. I used institutional ethnography for my PhD that I completed in 2020, and my interest was looking at the social organisation of maternity clinicians' work in relation to central fetal monitoring systems.
Lovely. Darren.
Hi, yes, I have a background as a registered nurse, and I'm currently working in a large tertiary hospital in Australia as a project manager to implement a range of quality improvement or performance improvement initiatives. And I do my PhD part-time, and I'm currently using institutional ethnography to explore the social organisation of implementing change programs.
Sounds fascinating. Grainne.
So hello, I'm Grainne Kearney. So I am an academic GP or family doctor and a clinical lecturer in Queen's University in Belfast. So I spend half my week in practice and half my week mostly in an education role for our medical school. So I'm delighted to take part in this today. I also used institutional ethnography in my PhD, finishing up in 2020, and I used it to interrogate, explicate a very dominant form of assessment that we use in the training of medical students, but also in the training of other healthcare professional students, that causes a lot of tensions for those of us who are also practitioners. So I'm looking forward to the discussion today, this morning, I will say, in our part of the world.
Yeah, thanks, Grainne. So just to give you a little bit more about me, I also used IE as part of my doctoral work, looking at the social organisation of cardiovascular disease prevention activities in family practice. So Grainne and I have some kind of overlap there in terms of our interest in general practice. But I'm not a clinician, so I've come to this having worked in healthcare services for a lot of my working life, but coming from a slightly different perspective. But I've got a real interest in kind of patient-centred research and how IE can help us to do patient-centred research. So yeah, let's move on to having a more of a discussion then about how we've used institutional ethnography, and just you know, what we've got out of using that, I suppose, to start with. So perhaps the first question then is to ask you how you came to IE, why you chose this particular approach, because to many people listening, they may not have come across this approach, and obviously we're not going to explain it all now, but there are lots of resources out there that you can use to find it, but it'd be interesting to know why you decided to take on this approach. So where should we start, Darren?
Oh, thanks. Well, how I found it was quite accidental, actually. I was just in the throes of trying to find a methodology that I wanted to use for my PhD research. And but look, as a clinician, I was always working from the premise of being patient-centred, or what I understood as being patient-centred. And then as I was working in my areas of change and leading change initiatives in the organisation, I still wanted to come from that perspective. And I was getting increasingly kind of frustrated, I suppose, with the work that I was participating in and doing, and thinking just before I came into my PhD that we were somehow losing sight of the patient-centeredness of the work we do. And so just I was interested, started off looking at, you know, how to kind of understand implementation better. And I soon discovered that one of the really rare territories that are explored in that space is the kind of social domains, or the social context of implementation. And so I was aware of that kind of gap, I suppose. And then when I'm looking for a methodology to do, to apply to my research, I just discovered in a textbook a little paragraph about institutional ethnography, and that paragraph sparked my interest to look a bit deeper. And then I discovered that this was the methodology that really resonated with kind of the context that I was looking at, and how I wanted to proceed with my research.
And I have Darren to thank for having discovered institutional ethnography, because we shared at the time a common PhD supervisor. So I was getting close to the end of my first year, and I knew that I wanted a critical, qualitative, feminist, ethnographic approach that meant that I could come to grips with people's lived realities of what was going on in their work environment, and had toyed with a few different ideas and was really coming up with blanks. And then our shared supervisor said, "Oh, Darren's just produced this and is, thinks that he wants to use this approach. What about this for you?" And I just immediately fell completely in love with institutional ethnography, because it met my needs in terms of all of the things that I had hoped to find in a methodology, and was really taken with it right from the beginning as I started to come to understand the potential for using it as a research methodology.
It's really interesting that you kind of say, Darren, that you pulled it out of a textbook, because I had exactly that same experience of reading a textbook on ethnography, and it was just a tiny little paragraph, but it made me, there was something that clicked with it, and then I started looking up some institutional ethnographic studies and thinking, oh, this is really quite different and quite refreshing. Having spent the first year of my doctoral work just going through masses and masses of different theoretical approaches and looking through and trying, I think it's quite a common practice that you do a lot of reading in the first year of your PhD, and just have this huge amount of stuff to wade through, and then you kind of select a methodology or a theory to work with. But at each one of them, none of them really kind of spoke to some of the experiences that I knew of from just talking to people. So, when I was listening to an online community of GPs, for instance, they were really worried about something called overdiagnosis, and they were recounting stories of people that were ending up on medications, for instance, that they didn't feel were very beneficial. And I was also talking to people within my own family that just didn't want to be on a statin medication, for instance, and thinking, but everything that I'm reading within the kind of official literature and the policy is talking in a different way about these people and what they should be doing. And it was just really refreshing to find an approach which acknowledged those tensions and acknowledged the different ways that you might approach a topic, and acknowledged experience. I think, like you were saying,
yes,
Kirsten, as well, acknowledge that you don't have to know everything from a textbook or from a piece of research that's published in a good quality scientific journal. Grainne, I feel like I've left you out.
No, I had a similar sort of chance meeting with IE, really, in that I at the time where I was in the early months of my PhD, and I had never heard of institutional ethnography, as I think you all were in the same boat. And I happened to go to one of Mike Corman's qualitative research methods lectures. It wasn't on my course, I just decided I would go, and he was working in Queen's University at the time. And he talked about general methods, but he talked particularly about IE as his expertise. And yes, I stayed behind after class, fired him lots of questions, and then we just entered into discussions at that stage. And Mike has very kindly stayed in touch and been a great help throughout my PhD and beyond. So yes, I think we've all slightly chance entries into this field. The other thing to say, I suppose, on top of what you've all said, which I entirely agree with, about sort of coming from the ground up, from practitioners, from patients, from their experience, and from them as subjects, not objects. Another thing that really works for me is this idea of, particularly in healthcare and in my world of healthcare education, the idea of neoliberalism becoming such a huge part of our world, either explicitly or implicitly, I'm not quite sure, but in the world where I work in education, words such as competence and accountability are now just common parlance, and for me, the IE provides a fantastic sort of opportunity to challenge that and resist it a little bit, ask about it. And certainly from we're in the world I'm in health and in healthcare education, I just see multiple opportunities. I know we'll probably come on to that a little bit in a moment. Thanks, Karen.
Great. Well, I'd rather than just constantly asking you questions as I was interviewing you, perhaps it would be helpful. Is there anybody that would like to just talk a little bit more about, what was useful to them, how IE was particularly we've talked a little bit about how it's a little bit different, but perhaps we can elaborate on that a little bit more.
I think for me, actually, Carolyn, it's interesting just hearing all of our kind of introductions there and how we came to it. But isn't it so interesting how IE in some way kind of resonated with who we are? It resonates with who we are as clinicians or practitioners or researchers in some way. And I think that's what I found really, helpful about using institutional ethnography, is because it allows you to be, reflective and reflexive, and values your own, has a way of valuing your own knowledges and your own experience. And particularly when you've spent so much time in a field, here is a method that allows you to bring that in. And so I think that was another one of those really appealing aspects of institutional ethnography.
But and I went in and did research in a field in which I'm a clinical expert, but what IE allowed me to do was to see beyond the horizon, so to speak. I had a fair idea of my direct clinical experience and what I was likely to find talking to people with similar experiences, but it opened out opportunities for me to go beyond that and to really develop a much deeper understanding of why things were the way that they were, that I hadn't managed to perceive just from my work as a clinician. So, that idea that you research up through the institution to understand things that are outside of your immediate experience was something that I really came true for me as an ability to extend my own knowledge, and obviously through publishing, to be able to share that knowledge with other people who occupy the same standpoint that I did at the beginning of the research.
Just to offer a slightly different use as well, I have on top of through learning of IE and learning about how you use it, and the things that it sort of brings to a fore. It's also helped me actually in my education side, which is quite interesting. So I obviously students, and again, I'm sort of conscious, this was such a, learning about IE was such a massive jump from the very positivist world that I've been educated in, and it's taken me a long time to unravel from that and sort of learn from the ground up again. But that skill is something I now sort of try to instill in students, to say, yes, you do need to know evidence, you need to find evidence, you need to critique evidence, but in front of you as a person, and what you need to do with them in combination is talk about how you can make that evidence work with them in their lives. What's their experience of it? How will it affect them? How, what's their opinion on it? And it's sort of that idea of, yes, there's evidence, but evidence isn't the be all and end all. It's what we use as part of the decision making process. It's not the only part of that process. And even the idea of work. So I've designed a teaching session where I try and get students to think about, when you're in a GP surgery, for instance, and a patient sits down, that is not the start of their health journey, if you like. You have to think about what they did, what decisions they made to come and see a doctor today. How did they actually do that? How many times do they have to try and ring to get through? Perhaps this is the only time they're going to go out this month. How did they get here physically? Do they drive? Do they have a car? Do they have to take public transport? How difficult was that? And what happens afterwards? And that's something that really, I can see students sort of really, it's like a light bulb moment where they realise that these people are not just here for this moment. They've got their whole life. And again, I think IE has helped me sort of, be brave enough to interrogate that, which is completely different than what they will learn when they go into their next class on physiology or whatever it might be, but sort of to be brave and to be a little different and to challenge in a different way and try and sort of broaden their mind about thinking about, healthcare as a people profession again, and not just a numbers or a statistics or in a very sort of evidence-based way.
So what you're referring to, Grainne, I think, is this idea that IE is not just a way of doing or looking or collecting data, but is so much more than that, and has a set of conceptual tools that help us to kind of consider what people do, and then Kirsten, you were talking about how we then go from there to look at how that's socially organised, and we might look at text, documents, electronic systems that actually coordinate what people do. And I think for me that's been a really refreshing thing with IE, that it isn't just about, okay, how do you look in an observational setting, or how do you do an interview. It's not just a practical set of instructions, but a way of thinking, and it's a way of kind of thinking and talking about research that you can take from place to place and apply in different contexts and in different ways, so people can use all kinds of, and I'm sure between us we've used lots of different methods within our research, but we use the same set of conceptual tools.
I think once you've oriented to the framework, to that way of thinking, it becomes difficult to unthink it once again. And it is, as Grainne's found, it's been useful in her academic career. It's been useful for me as a clinician and a manager within a healthcare organisation. For me to have the tools to go, right, how does this relatively new healthcare organisation that I've moved into get work done? What happens when I report to someone? What do they do with that information? And it's helped me to get up to speed a lot faster in this organisation, because I know where to go looking for that bit of information to understand how things get done the way that they do here. And so, yeah, while IE is most definitely applicable as a methodology, it really is so much more than that.
I think it's a little bit like a mother tongue now, as a way of kind of, my first language, and that you can do other things and do research in different ways, but that's my primary way of thinking.
I was just going to say, Kirsten's coming off of, it's really interesting, isn't it, when you've worked in a profession or in an organisation for so long, and you think you know it to a certain extent, and then you use institutional ethnography, and it just unlocks this kind of door to this all these other layers that you can kind of start to piece together and map these connections that you didn't realize were necessarily there before. So it's very illuminating, even in context that you think you've understood for some time.
So it helps you make your familiar. Sorry, Caroline.
I was just thinking, yeah, I think you were going to say it kind of makes the familiar strange a little bit, yeah, which is exactly true. And I think that speaks, Grainne, to you know, this whole, I think there'll be some people that listen to us chatting and thinking, you know, well, IE is quite clearly a biased way of doing research. You know, this idea of bias comes into a lot of our thinking, doesn't it, across research and health. And I think we're just touching on something around how we deal with that, because we do come into it, you know, from our own experiences, taking those experiences as being some form of valid way of knowing. But then we're moving on to actually looking at how those experiences are put together and being quite disciplined around how we follow certain kind of textual processes through. Did any of you want to say any more on that and how you kind of handle that that accusation, maybe even sometimes, that your research is a bit biased?
I would love to see that everyone who publishes is a bit of positivist research in a randomised control trial has to actually write a researcher positionality statement in the same way that we do as qualitative researchers, because I would reject the idea that only qualitative researchers are biased. I think all of us have beliefs, assumptions, values that we bring with us into our research, and they're not, I don't see them as problematic, but we clearly occupy a standpoint, as Dorothy Smith would describe it, in the world where we occupy a particular position in relation to knowledge, and that shapes the way that we see the world, understand the world, and act in the world. And I think as researchers, it's really important to make that explicit in our writing and then show why we made the choices that we did and how those articulate to the data and lead to the findings, so that somebody can follow along behind us and say, okay, I can see how you got from A to B. That makes sense to me. And if they occupy a different standpoint, they may arrive at a different point B than the one that I arrive at. But the rigour in the research process is for them to be able to understand, well, I can see that occupying the space that you do, how you got to where you got to.
I think it's something that we're probably all still learning how to articulate to the different audiences. And I know Caroline and I have talked about this a few times, you know, how I will describe it if I've got a room full of clinicians compared with, say, whenever we were at the ISA conference, all of us earlier this year. So there's we have a very different way of, and actually another thing I learned from IE is the fantastic tradition of using research examples, if you like, to explain the ideas. So certainly whenever I started into this world and reading Dorothy Smith's work, you know, it took me a lot of reading to try and get my head around it. And then when you read somebody's work, what they did, actually, that's when you really could make those connections and understand it and see how it was useful. So quite often now, if I'm speaking to people who are medics, I will use the example first, and there's lots of fantastic examples, such as Fiona Webster's work, that I know will resonate with them about, you know, waiting times being the most important thing in an accident and emergency, you know, things that we know not to be the case, but that's how it might be. If you look from a top-down way, I think using the examples is a really good way of getting through to people who, yes, like us, have been taught in a different world, and you know, in a 20-minute talk, we're not necessarily going to change that or undo that. We can challenge it and we can point it out, but I always feel that using examples is what people really, it resonates with them, because often it is those shared experiences that have driven them nuts as well in their day-to-day work when they're trying to do a good job.
And I think people, really people on the ground really appreciate it when you can articulate something from an institutional ethnography that makes sense of their own experiences. And quite often it's not something which they would have said, well, I didn't know that metric existed, or I didn't know that there were, implications of funding systems. But yet in research we often don't talk about those things that are hidden from view, that are not directly seen as being a part of patient care. So we might not talk, it's the way that the contract's set up, or the way that the financial incentives are put together is seen as a kind of back office function. And yet when you start looking at what people do and following through those work processes, you find that they actually really do impact on what people do on the ground. I think that is, from my experience, I've had really positive feedback when I've talked to clinical audiences where they've gone, yeah, that is exactly what's going on. And I'm sure you all have too, yeah, by the nods.
It's almost consoling to people because I think you're right. I think a lot of people, they know that, that neoliberalism is there and having an effect, but they have an awareness in a way, but it's not in the forefront, or it's not highly visible to them. And then when you can show them examples, I think, and take them through the IE, they can see it and it makes sense, and it's almost in a strange way comforting to see it, because so many people, I think, are working on the front line that are frustrated by it all, and when they can see kind of examples of how IE can shine a light on it and make it visible, then it somehow is almost reassuring.
I think rather than aiming for generalizable knowledge, I think the thing that IE has offered for me is transferable knowledge. And I realised when I was looking earlier today that it's exactly 2 years since I came and visited you in Ireland, Grainne. And I spoke in Ireland and in Scotland and in England while I was over there about my research. And every single time I spoke, midwives would come up to me afterwards and say, oh my God, that's exactly the same thing that happens in my hospital, with a different brand of fetal monitoring system, with a different policy environment, in a different location, under different regulatory rules, but the same behaviours were happening. And so, while some of the detail about how maternity clinicians work with socially organised are going to be different from where I'm doing my research to the experience that these people have, the fact that they could identify the same thing so clearly spoke volumes to me about Dorothy Smith's concepts about ruling relations and how globalised they are, and that, I certainly can't make claims of generalisability from my research, but that aha moment when people go, oh, that happens here as well, I think that's what we're seeking in terms of, the rigour and the value in institutional ethnography.
Well, I wonder whether, as we're almost at a half-hour chat, and we may be, that may be a good time to wrap up. So, yeah, thank you, Darren, Kirsten, Grainne, for chatting with me this morning, and hopefully it'll be the first of some similar conversations, and that will get other people talking within the IE and the SHI network. And just to say that, perhaps our conversation today does emphasise the need for something around a SHI network. We all started off with maybe looking in a textbook or finding ourselves in a position where we didn't have a lot of support around us for using the IE approach, and we're hoping that by building connections, by introducing ourselves, that helps other people that are in a similar position to get to grips with this approach. So thank you very much.
Thanks.
Thanks, Caroline.